This is EM Cases EM Quick Hits podcast. Quick, let's get on with it. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCASES. TEE in cardiac arrest. Well, we know that early defibrillation and high-quality CPR are the two most well-established lifesavers in cardiac arrest. But what if I told you that chest compressions in some cardiac arrest patients causes outflow obstruction, rendering the almost dead patient totally dead with almost no chance of survival? I'll let you think about that one for a bit, and we'll come back to it in this EM Quick Hits segment on the utility of transesophageal echo, that's TEE, in cardiac arrest. And to help us answer this question and many others I have about TEE in cardiac arrest, it's a pleasure and an honor to welcome Dr. Ross Prager, an intensivist from London, Ontario, who has a special interest in point-of-care ultrasound. Welcome, Dr. Prager, to EM Cases.
Hey, thanks for having me.
All right, let's jump right in, and I'll ask bluntly, why should I care about TEE? I mean, I've heard all kinds of claims, from allowing feedback on the quality of chest compressions to minimizing chest compression interruptions to identifying reversible causes of the arrest to helping get correct rhythm interpretation, even prognostic information. Can you just explain the general rationale for TEE in cardiac arrest?
Yeah, and to start, I just want to distinguish between kind of what I'd call comprehensive transesophageal echo, or TEE, and resuscitative TEE, which is really what we're talking about when we talk about TEE in cardiac arrest. Comprehensive TEE systematically assesses filling, function, valves, whereas resuscitative TEE really answers goal-directed questions for the sickest patients. And cardiac arrest is probably the best use case for resuscitative TEE. There's 4 things that I really look for when I'm using resuscitative TEE in cardiac arrest. The first is to identify the etiology of arrest. Next is to improve CPR quality. The third is to identify rhythms that aren't seen on surface electrodes, like fine ventricular fibrillation. And the last is for some procedural guidance.
Okay, it sounds like TEE and cardiac arrest can do a whole lot of things. I just want to break down each of those things individually. Let's start with the first one and talk about the etiology of cardiac arrest that you can find with TEE. So getting an idea of what the most likely reversible pathology is so that you can fix it and stop the cardiac arrest.
It can be really difficult to identify the etiology of arrest on surface echo or POCUS. In fact, it can actually detract from CPR quality if you spend time delaying pulse checks to look for that subtle clot in transit, for example. The evidence shows that TEE can identify the etiology of arrest in 25 to 35% of cases, and actually identify very actionable things like clot in transit, evidence of severe hypovolemia or dynamic left ventricular outflow tract obstruction, or pericardial effusions that might be missed on surface echo.
So that's the reversible pathologies. What about allowing feedback for the quality of CPR?
For anyone who's done surface POCUS, we know that different patients have hearts in different locations. It sounds kind of counterintuitive, but for some patients with hyperinflated lungs, their heart is actually, you can identify it below the diaphragm or below the ribs. When you have a patient with cardiomegaly, sometimes you find the apex on POCUS in the axilla itself. What this means is that when we apply a one-size-fits-all chest compression, where we compress on the lower part of the sternum, for some patients we compress over the left ventricle, which is what we're going for. But for some patients, we actually compress too high, and we compress over the left ventricular outflow tract or the aorta. And the problem with this is that when you perform compressions too high, you actually don't get any ejection of blood. The aortic valve doesn't open. And when you don't have ejection of blood and the aortic valve isn't opening, the rates of return of circulation are much lower compared with when you do CPR over the left ventricle. But unfortunately, there's no way to tell just by kind of empirically going where you're compressing and whether or not you can optimize chest compressions.
Wow. So there's a huge chunk of patients that even if we do incredible resuscitation of cardiac arrest in every other respect, if you've got the palm of your hand even just a few inches too high, as we know, chest compressions are the most important part of cardiac arrest. You can pretty much screw up your entire resuscitation just by being a few centimeters off with your hands on the chest compressor. Really interesting.
And to add to that even further, by repositioning your hands maybe a bit down, maybe a bit to the left, you can actually start improving your CPR quality. And you can see that in real time with blood being ejected out through the aortic valve into the aorta to the rest of the body. You see end-tidal CO2 improve. You see diastolic blood pressure if you have an art line improve. And so really this unlocks a complete new dimension to resuscitating cardiac arrest by tailoring CPR position to individual physiology and anatomy. It's amazing to see. And I've seen cases where early on in arrest, the end-tidal CO2 is 8 or 10, and you're thinking, how is this possible? This was a witnessed VF arrest in the cath lab. But when you position CPR to the optimal location, the CO2 jumps up to 40, the end-tidal CO2 jumps up to 40, and suddenly you have the patient moving with your CPR quality. And it's all just because we're compressing over the wrong part of the heart.
All right, I love that. We're going into the fourth dimension here with with TEE and just hand position of chest compressions. All right, so we've talked about improving quality of CPR. We've talked about identification of reversible pathologies. What are some of the other things that TEE during cardiac arrest is good for? What other rationale do we have for it in cardiac arrest?
TEE can identify cases of fine ventricular fibrillation that aren't seen on surface electrodes. For example, in patients with obesity or a lot of tissue between the electrodes and their heart, really fine electrical activity can be missed, and this can be seen on TEE and potentially successfully defibrillated. And this can happen in up to 10% of cases based on the literature. It can also distinguish pseudo-PEA from true PEA. When you identify the contraction and you don't feel a pulse, sometimes it might warrant maybe having another feel of the pulse or placing an art line to help guide that resuscitation. And I've certainly had cases where providers report they don't feel a pulse, but when you look at the heart, it's rigorously contracting. You say, just hold on a second, have another feel there, or you feel yourself. And you actually might identify a pulse, and you've actually obtained ROSC, and additional CPR may not be necessary and could be harmful.
Yeah, we did a great episode with Rob Samard on pseudo-PEA way back. So I do encourage listeners to check that out. And if this can solve the problem of pseudo-PEA and prevent all those pauses in pulse checks, I mean, even just right there, you've got a great advantage. This all sounds wonderful and great. But of course, I'm sure our listeners are thinking, just like I'm thinking, what is the evidence for all of this? So there are these amazing claims that we just listed. My understanding is that these claims are based largely on retrospective data. I don't think there are any RCTs for TEE just yet, but could you just go over for us what evidence there is for TEE to date? And we're recording this in June 2024.
A lot of the resuscitative TEE literature has been limited to single center, either retrospective or prospective observational studies. And we actually covered this in a scoping review. And for the cardiac arrest population in particular, we found a few things. The first is that TEE is definitely feasible to do in cardiac arrest. And we've seen that at our own center just anecdotally, and the many providers worldwide that do this. The next is that it may be associated with shorter pulse checks, particularly when you compare it to surface transthoracic echo. Third is you can identify etiologies of cardiac arrest that are not seen on traditional POCUS. The next is that when you position CPR over the LVOT and aorta, you have worse survival, particularly ROSC, compared with CPR over the LV, and that repositioning CPR is associated with better hemodynamics, for example, diastolic blood pressure and tidal CO2, important metrics of CPR quality. Ultimately, evidence that resuscitative TEE improves survival for cardiac arrest is not there yet, but that's actually something that we're studying as part of a large prospective multi-center study, the resuscitative TEE registry led by Felipe Turan. And there's over 50 centers worldwide recruiting patients trying to answer these questions. Can CPR quality be improved? Does CPR performed over the LV result in better long-term neurologic survival for cardiac arrest patients? And ultimately, this will set the way for a prospective randomized controlled trial of TEE in cardiac arrest.
All right. So far, we've got some pretty convincing retrospective data, but of course, we all know that retrospective data is nothing we can hang our hat on. It looks like the evidence is in evolution, but it does sound hopeful that we will be able to get some RCT evidence. It all makes a lot of sense. The next question that I always have with these kinds of things is sort of the logistics. Before we get into the logistics of making this work properly, we need to talk about kind of step by step how it's actually done. I've never done a TEE before, but I can't imagine that sticking a probe down someone's esophagus is an easy thing to do. So how do you do it? Can you just take us through sort of a step by step of how you perform a TEE in the midst of the chaos of a cardiac arrest?
I'd probably counter that and say it actually is easy compared to many of the skills that are performed in the emergency department every day. Really, you're putting a tube down somebody's esophagus. If you can put an oral gastric tube in, it's really similar to putting a TEE probe down. Now, we limit resuscitative TEE in all situations to intubated patients. That makes the procedure a lot easier because they're well sedated, they're relaxed, and it just makes the procedure safer for the patient and easier to do. During cardiac arrest, there's often limited physical real estate on the trunk of the patient. You're jostling arms of the people actually performing CPR. So often this is done from the head of the bed. Especially after the patient's intubated, there's often not a lot going on at the head of the bed. And so with a bit of real estate, you can either do this yourself or with somebody else. If you're doing this yourself, with one hand, you can do a jaw lift, and then you insert the TEE probe midline and just gently place it into the esophagus, and similar to an oral gastric tube. With two people, or if you're having a little bit of difficulty, you get somebody else to hold a jaw thrust, and then you insert the probe yourself. If you've just intubated a patient, you have a laryngoscope at the head of the bed, you can easily just use a video or direct laryngoscope to place the probe. And I know that many physicians in cardiac arrest, myself included, if that's available to me, I'll just jump right to that because, again, you can visualize the glottis and you don't want to, it's sometimes counterintuitive because you're actually trying to place it posterior instead of going anterior through the cords there. And so you place it posterior into the esophagus. Ultimately, there's great evidence to show that after about 10 to 20 insertions, providers from any specialty are very comfortable and capable of inserting the TEE probe. And I think most people, after they've inserted it, say, wow, that was easier than I expected.
All right, great. Yeah, just the fact that you're doing it after endotracheal intubation, there's only 2 holes there. You've already filled 1 hole, so the second hole should be pretty easy to get into. All right. So you mentioned that sometimes there can be a bit of a challenge, but that is generally pretty easy. What are the biggest technical or logistical challenges for doing TEE in cardiac arrest? Once you've got it in, that's one thing, but what about, getting images and while chest compressions are going on and while everything else is going on, what are some of the biggest technical and logistical challenges that you have of getting some good images that are actually going to help you for the differential diagnosis, the underlying causes, for the quality of CPR, for all the things that we listed at the top?
From a logistical perspective, the hardest part is actually finding the cognitive bandwidth to do this when you have other interventions. So I find that this often is easiest to do in what I would call a routine medical cardiac arrest. You're going down the ACLS algorithm, the patient's intubated, you're giving meds, you're doing CPR, maybe you're defibrillating them, but there's not much else going on. In these patients, often there's a bit of a lull in the emergency department or the ICU, and this is a great time to reach for the TEE probe because that's something further that you can optimize for your CPR quality. When you're placing multiple chest tubes and doing other procedures, it can be a lot harder to find the time and the personnel to do this. The next is from a technical perspective, once the probe is in, there's very little you need to do. The esophagus is right behind the heart. So once you put the probe in, you get the view of the heart there almost in 99% of the patients immediately, and you have the perfect view. And all you need to do once you have the view is hang it up somewhere or hand it off to somebody else, and the view stays there. It's not like a surface echo where it's sliding around and you have to continuously reposition. There's very limited mobility of the probe once it's in the esophagus, other than up and down. And so if you don't push it in further or pull it back, the image stays very, very static. And you can then use that to serially monitor the LV function, the RV function, and also the CPR quality. The other challenge, I think, is logistically in terms of storage and having it accessible. So having it available in your recess room in some sort of plastic tote or plastic box that's available, sending it down for processing after, and we can certainly talk about that later. But those are probably the more logistical challenges from acquiring TEE for an emergency department, more so than for an individual patient.
All right, great. So those are some of the logistical challenges and how to overcome them. Doesn't sound like there's actually too many. What kind of probe is this? I mean, I'm imagining this is not one of the standard probes on a POCUS machine. How do you get them? How much do they cost? Are they easy to find?
I think that's one of the challenges of starting a resuscitative TEE program for any department. You do need a special TEE probe. They kind of look like endoscopes if you're familiar with a gastroscope or a colonoscope. And each brand has a probe that can hook up to most of the available POCUS machines that you would find in an emergency department. So you just have to get the probe that fits with whatever machine. They are more expensive than a traditional ultrasound probe because they have the ability to kind of move internally using some knobs. But once you have them, they actually last a really long time if you maintain them, keep them cleaned, and if you restrict access to people who know what they're doing so that there's less kind of trauma to the probe itself.
Yeah, makes sense. I want to talk a little bit about when things go sideways and the risks of TEE. The one thing I was thinking as you were talking is what if you have if you have a soiled airway, you manage to clear that and you manage to intubate the patient, suctioning and all of that. Usually from a soiled airway, if someone's vomiting and this is all coming up through the esophagus, do you ever run into that sort of problem when you're intubating the esophagus? I'm assuming that all these patients are going to be paralyzed, but what do you do with the challenge of the patient who has gastric contents coming up into the esophagus and blocking your view?
The risks of TEE in general are quite low. And we actually did a scoping review and looked at the complications of resuscitative transesophageal echo. And the two main complications we worry about the most are death and esophageal perforation. And out over 6,000 cases, we didn't identify a single case of death or esophageal perforation resulting from resuscitative TEE. Other concerns are things like that are more related to sedation and airway management. And as you said, if you restrict it to patients who are already intubated, the sedation risk becomes negligible, as does the airway protection risk. So then we worry more about things like oropharyngeal trauma or bleeding. So if in the case you described the patient was vomiting blood, I would not insert a TEE probe. If you think that the patient is having an active GI bleed, that would be a fairly strong relative or absolute contraindication depending on who you talk to. Vomiting itself, though, the airway is protected. There shouldn't be a concern there. And in fact, it doesn't interfere with your images. We often do TEE on people that are non-fasted because this isn't an outpatient cardiology performed TEE where the patient's NPO since midnight. These are patients that have cardiac arrests on the street, in the emergency department, in the ICU. And we often deal with full stomachs, and it does not impede image quality at all. If anything, it acts kind of as an acoustic medium. We're quite good at imaging through water and through other kind of semi-solid and liquid content. So it doesn't impact the quality of the images we obtain at all.
That's interesting. You almost want your patient to be vomiting to get a better image.
I don't know if I'd go quite that far, but certainly.
Yeah, joking aside, I want to get back to the question that I posed at the top of the segment about outflow obstruction. So again, there's this concept that in some patients in cardiac arrest, chest compressions will impede cardiac output. I mean, you already had mentioned that if you have your hands too high up on the chest, you're going to be just compressing the aorta and not the LV. Can you explain the concept of how TEE can help in cases where compressions are actually impeding cardiac output?
The literature shows that in about 50% of cases, 50, compressions are done over the left ventricular outflow tract or aorta when a TEE probe is inserted. That's 50% of patients where CPR quality is suboptimal. There's no opening of the aortic valve. There's very limited forward flow of blood even leaving the heart due to chest compressions. And the evidence shows that the rates of return of spontaneous circulation are much lower. And what we're actually looking at is what are the rates of neurologically intact survival at a longer time period, and data is still coming out on that. But what we know is that if you identify this and you reposition CPR, typically inferior and sometimes a little bit to the left, and you compress over the left ventricle as opposed to the LVOT or aorta, immediately you see a change in the CPR quality in real time in front of you. That aortic valve that was closed starts opening. You start seeing blood being ejected from the left ventricle. You see the hemodynamic effects of that as well, with increasing diastolic blood pressure, which is associated with ROSC, increasing end-tidal CO2, a great marker of perfusion during CPR. And so I think that this is really something that needs to be explored. How do we make this a more scalable solution, not just to patients with a TEE probe in situ, but for all patients with cardiac arrest? Does this mean we need to change where we're doing CPR? The American Heart Association recommends the lower part of the sternum, but is there actually a better position that we should be doing CPR that's safe and more effective? Is there a non-invasive way to determine whether we're doing CPR over the LVOT or the LV? For example, if you're doing CPR and your end-tidal CO2 is 15 or 20, perhaps part of the optimization of the CPR quality, if the depth is good and the recoil is good, is maybe moving down a little bit into the left. And if that end tidal goes from 15 to 25, maybe that's something to mark to all the other CPR providers. Hey, this is a new location we need to be doing CPR at. Now, the questions about safety and efficacy of doing CPR in non-standard locations certainly need to be raised and explored with prospective research. But it's an exciting and potentially game-changing scenario where we could actually be doing better CPR for all patients if we can take the lessons learned from TEE and apply it broadly for all the patients that we're seeing in the emergency department and beyond in the pre-hospital world.
Yeah, I mean, even just that alone, improving chest compressions, because we know that is the most effective life-saving thing that we can do in cardiac arrest. And so just that alone, it seems like TEE would be worthwhile pursuing. But again, we're not fully there in terms of the research. What do you think the most pressing research questions are that need to be answered before TEE and cardiac arrest becomes like standard of care?
I think we need interventional studies showing that implementing TEE into cardiac arrest care improves outcomes. And the reason why is even if we demonstrate that CPR over the LVOT or aorta is bad, and that we can reposition this, and that repositioning it is associated with better hemodynamic effects, whenever you introduce a complex intervention like TEE into an existing pathway, there's a risk that you make other aspects worse. Could we result in delays of early CPR because now everyone's trying to intubate the patient to put a TEE probe down? And I think ultimately we need to show that integrating this one technology into a system of care improves outcomes for patients in the emergency department. And that's certainly something that the resuscitative TEE registry has its eye towards. We have over 50 centers worldwide recruiting patients right now observationally. And then the question is going to become, all right, when are we ready to do the randomized control trial that really looks at this and demonstrates definitively whether or not TEE improves outcomes or not?
All right. Any last burning answers you have for any of the questions we've already talked about, Dr. Prager, or any cases maybe that you could, illustrative cases that you could give us?
Yeah. If there's one place where I think that TEE will improve outcomes from cardiac arrest, it's really in positioning CPR. But the problem is most people don't have a TEE probe today. How can we use these learnings to actually improve CPR for all of our patients right now? And I think probably the best situation is when you see a patient who's arrested in front of you, a young patient, and you have them intubated within 5 or 10 minutes, and you start doing CPR on them, and their end tidal is like 5 or 10 or 15, something lower than you expect. Those patients, invariably, you're doing compressions over the LVOT or the aorta. And if you go down maybe 2 inches in your compression location, and sometimes over to the left, maybe 2 inches as well, I've seen a case, and just this one case that really stands out to me, a young guy that arrested in front of us. We got them intubated within 5 minutes, but the end tidal was super low. We were shocking them VF, and we kept shocking them, and they weren't getting ROSC. And finally, when we put the TEE probe down, we saw that the compressions were being done over the LVOT and aorta. And when we moved the compressions down, the end tidal went to 35. The patient actually opened their eyes and started trying to move while they were in VF. And we had to sedate them while we were doing CPR. And we eventually then shocked them back and got ROSC and got them to the cath lab, and everything was taken care of. And really the clue was this patient should have had a higher end tidal than what they did. 10 minutes after a cardiac arrest, in a young person that arrested in front of you with bystander CPR, they should still have pretty good perfusion. And so don't settle for a low end tidal, even if the depth is good, even if the recoil is good. Think that there's another dimension to CPR, and that's actually the planar space where CPR is being done, and whether or not it's too high, too low, too left, too right.
Wow, Dr. Prager, you're incredibly reasonable in your your approach to this, because I find over the years when there's something new that comes out, especially a toy that comes out in emergency medicine, the people who are at the forefront of it are extraordinarily keen and eager, but perhaps their eagerness has made them not quite as reasonable as you've been in helping us understand more about TEE. So thank you so much for your contributions here and your expertise in this topic. I look forward to doing another interview with you in a few years when we have some more RCT data.
Absolutely. Thanks again for having me.
This show is sponsored by BetterHelp. How do you stay cozy during the winter months? For some, wrapping up in a blanket with a mug of hot chocolate or watching a movie with the family is the best way to spend the month of December. Therapy is a great way to bring yourself some comfort that never goes away, even when the season changes. Talk therapy has innumerable benefits, from overcoming burnout to improving relationships to being more self-aware. If you're thinking of starting therapy, give BetterHelp a try. They make it easy to fit into your schedule and easy to get matched with a licensed therapist. Find your comfort this December with BetterHelp. Visit betterhelp.com/emcases today to get 10% off your first month. That's BetterHelp, HELP.com/emcases.
Anton sent me a paper for the Quick Hits, and actually it's a paper that caught a few people's eyes. People love ketamine for analgesia these days, and people are fascinated with alternative mechanisms for providing medication. So an RCT of nebulized ketamine was just too good to pass up. So this is Campen et al., a non-inferiority randomized trial comparing nebulized ketamine to intravenous morphine for older adults in the emergency department with acute musculoskeletal pain. It's in the journal Age and Aging, January 2024. And it's a well-designed trial of elderly patients presenting to the emergency department with MSK-based pain and at least 5 out of 10 pain on a pain scale. They compared 0.1 milligrams per kilogram of IV morphine to 0.75 milligrams per kilogram of nebulized ketamine. And they were looking for a reduction at pain at 30 minutes. It was a properly blinded trial, so you either got nebulized or intravenous saline as a placebo depending on your group to go with your active medication. They started with a reasonable dose of morphine, that's 0.1 milligrams per kilogram, but we know that dose still only gets about half of patients to adequate pain control. Despite that, for some reason, they then switched to fentanyl rather than just sticking with a single opioid, and that seems weird to me. Why mix drugs? Why not just stick with morphine? They ended up enrolling 261 patients, and pain scores dropped by about 2 out of 10 in both groups at 30 minutes. They went from about 7 to about 5 in both groups. This allowed them to conclude that nebulized ketamine was non-inferior to intravenous morphine based on their threshold of 1.3. That's a non-inferiority threshold. The 95% confidence interval actually went to about 0.5. Now, I think non-inferiority trials might be the most misunderstood part of evidence-based medicine. Non-inferiority trials are not equivalence trials. They don't prove that two treatments are equal. The way a non-inferiority trial works is that the researcher picks, often out of thin air, a margin that they think is acceptable. That margin is how much worse the new drug is allowed to be. And then we conclude that a drug is not inferior if the 95% confidence interval does not cross that margin. So even though we call these trials non-inferiority trials, really the inferiority is baked in. The goal is just to show that the new drug is not much worse than the older drug. Not much worse. Now think about that. Do you really want drugs that are not much worse? How often is that the outcome that you want? How often is that the outcome that patients want? Not much worse. So why do we do these kind of trials? Well, you're really only supposed to do non-inferiority trials if the new drug or treatment has already been proven to be better in some way. That could be convenience or cost or lower adverse events, but it has to be better in some way to justify a non-inferiority trial. So when you read a non-inferiority trial, you really should read the conclusions with those two facts in mind, and your conclusion should always sound something like this. Drug A causes no more than 8% higher mortality than drug B, but I'm willing to accept that because a once-a-day drug is way easier than a 3-time-a-day drug. or drug X is no more than 25% worse than drug Y for controlling pain, but we're willing to accept that because drug X is cheaper or has less adverse events. That's how non-inferiority trials should be read. So what would that sound like for this paper? Well, in terms of short-term pain control, you can expect the pain relief from nebulized ketamine that might be as much as 1.3 on an 11-point scale worse than morphine, but no more worse than that. And we are willing to accept that because this part gets a little bit questionable because I don't know that it's fully proven, but we think that nebulized ketamine is going to have fewer adverse events. Then you can decide whether that makes sense to you. Now, aside from the issues with a non-inferiority design, I think there are some basic issues of logic when it comes to ketamine for pain control, especially in this setting. Don't get me wrong. I work in a population with a very high rate of both past and current opioid dependence and abuse. I understand the need for opioid alternatives. And for very short-term analgesia, like controlling pain well enough to get an adequate x-ray done, I think ketamine is a great option. But really, these authors sort of undo their entire argument for ketamine in their introduction. They talk about how elderly patients are more likely to have prolonged significant pain. So what are you going to do after this one dose of nebulized ketamine? What are you sending these patients home on? Does a couple hours of pain relief really matter if the injury is going to cause pain for weeks? And given we know there's lots of side effects from morphine, wouldn't you rather know about that in the emergency department? Wouldn't you rather know if your patient can tolerate oral morphine before you send them home to puke their guts out for the next 5 days? Look, knowing that you can nebulize ketamine is a fine tool to have in the toolbox, but I can't see myself doing this anytime soon. For me, I'll stick with oral morphine in the vast majority of patients with severe pain, and I'll reserve ketamine for that rare scenario where opioids are truly contraindicated and all I really care about is very short-term pain control with no concern about long-term pain control.
All right, fair enough. I mean, I agree generally speaking with Justin, but I think I'll still use nebulized ketamine in one specific situation. And that situation is in the patient where IV access is difficult. They've tried various analgesics at home that aren't working, and they're obviously suffering in pain in the ED. In these patients, I want rapid pain control for my patients. Sure, I could use intramuscular or oral morphine or IM ketamine, but if I want rapid pain control, nebulized ketamine is likely to work significantly faster than either IM or oral routes. And once we get IV access, then I agree, there's really not much of a role for nebulized ketamine. Do let us know what you think about nebulized ketamine in the show notes for this quick hit. All right, next up we have Hans Rosenberg with his Best of CGEM Just the Facts. And this time he's going to be talking about a condition that we see almost every day in the emergency department, and that is cellulitis.
Welcome to another Quick Hits collaboration with CGEM and EM Cases. Today, I'm joined by a great friend, colleague, and ED master of skin and soft tissue infections, Dr. Krishin Yadav. He's here to discuss his recent publications, Canadian Emergency Department Best Practices Checklist for Skin and Soft Tissue Infections. This was a 3-part series, which included cellulitis, skin abscesses, and, of course, necrotizing fasciitis. Welcome, Krishin.
Thanks for having me on, Hans.
Of note, we're not going to go through the entire checklist, but rather covering the topics which were not covered on a couple of previous great episodes, which were EM Cases episode 109, Skin and Soft Tissue Infections, as well as Best Case Ever, Necrotizing Fasciitis. Now, before we get into the meat of this podcast, I wanted to ask you to briefly discuss how was this checklist derived?
Skin and soft tissue infections are one of the top 10 reasons patients visit the emergency department. Prior research has shown that up to 1/3 of patients can be misdiagnosed, and there is an overuse of IV antibiotics and high rates of hospital admission. With this in mind, our team felt that there was a need to better standardize how ED patients with SSTIs are managed and diagnosed. The problem is that existing guidelines are not tailored for use in the emergency department setting. We formed a group of key stakeholders, including emergency physicians in academic and community sites, infectious disease physicians, ID pharmacy, and patient partners. And all 3 checklists have gone through an endorsement process with the Canadian Association of Emergency Physicians.
Awesome. I really love that you guys had not only academic physicians, community physicians, but also patient partners and other non-physician colleagues helping you with this. All right. when should an ED clinician consider IV antibiotics for treating cellulitis?
The checklist strongly emphasizes that most patients with cellulitis should be treated with oral antibiotics. However, a patient should be treated with IV antibiotics if they cannot tolerate oral intake, for example, due to vomiting or a malabsorption syndrome. IV antibiotics should also be used if a patient has failed a 48 to 72 hour course of appropriate oral antibiotics and are now presenting with worsening infection, fever, and/or significantly worsening pain. Finally, IV antibiotics should be used in patients who are systemically unwell, such as hypotension or persistent tachycardia.
Now, I've always wondered, besides antibiotics, are there any other non-pharmacological therapies that can help patients? For example, is elevation of the affected area recommended?
Our recommendation fully agrees with the IDSA guideline recommendation. Ask your patients to elevate their limbs for cellulitis. This will hasten improvement and recovery by gravity drainage of edema and inflammatory substances.
Now, for non-antibiotic pharmacological treatments, should I be adding anti-inflammatory agents?
This was an interesting question that our group had. The IDSA recommends considering corticosteroids in non-diabetic patients, but this was based on a single RCT of 112 inpatients with erysipelas randomized to a course of prednisolone or placebo. We felt that more evidence was required. Ultimately, I helped co-lead a systematic review and meta-analysis to answer this question, which was recently published in CGEM. In this review, we identified 5 RCTs that assessed NSAIDs or corticosteroids as adjunct treatment of cellulitis. The evidence suggests that patients given an oral NSAID plus antibiotics have an earlier clinical response compared to antibiotics alone, although importantly, there was no difference seen at 5 days or cure up to 22 days. There wasn't enough evidence to make a conclusion for corticosteroids. We ultimately recommend considering an oral NSAID for 5 to 7 days as adjunct treatment for cellulitis, so long as your patient does not have a clear contraindication.
And now for my final question about cellulitis. Which ED patients with cellulitis should be considered for hospital admission?
None of the guidelines that are currently out there discuss when patients should be reassessed for cellulitis. This is key for us as emergency physicians, as discharge instructions are so important in an era when many patients do not have access to a family doctor and may come back to the ED. I led a systematic review and meta-analysis to answer this question, along with a group of fantastic emergency researchers in Australia and New Zealand. This systematic review included 32 randomized trials and more than 13,500 participants to assess the impact of antibiotics over time to treat cellulitis. The best available evidence from this review suggests that the optimal time to clinical reassessment is between 2 to 4 days. Our group felt that recommending reassessment at 48 hours was too soon and may lead to premature escalation or change in antibiotic treatment. Thus, we recommend patients with cellulitis should be reassessed at 72 hours if having no improvement or some worsening. We also point out that patients should be asked to return sooner if developing unusually severe pain or rapidly spreading erythema, which may be concerning for a necrotizing process.
Fantastic. So that was a whole lot on cellulitis, and that's it for part 1. We'll chat more the next time about skin abscesses.
Thanks so much, Dr. Rosenberg and Dr. Yadav. You know, it's good to know what the guidelines and evidence suggest for such a common condition, such as cellulitis, that has such a wide practice variation. I must admit, I usually neglect to recommend elevating the limb to my patients with cellulitis, so for me, that's a practice changer. All right, next up, we've got Dr. Mathew McArther, who you might remember from his great quick hit on penicillin allergy and penicillin challenges in our EM Quick Hits 56 episode. This time, he's going to present the evidence for using subcutaneous insulin protocols for mild and moderate DKA, and why we should probably be switching from IV protocols to sub-Q protocols in all but the severe DKA patients. But before we do that, a message from our sponsor, Easy Recess. Easy Recess is thrilled to announce that they are now available for institutional access. In addition to providing the app for all employees in your organization, this means access to exclusive features like printable protocols with calculated medication doses, customizable content to fit your local protocols and practices, access to Easy Recess on computers via the web-based version, and much, much more. To learn more, visit the institutional license section at easyrecess.com. And as always, you can download Easy Recess and use the promo code EMCASES, that's EMCASES, one word, to get your 2-month free trial on an individual subscription.
As Emerge Docs, diabetic ketoacidosis is part of our bread and butter. As we know, the mainstay of DKA treatment involves administering insulin and correcting hypovolemia and electrolyte derangements. To accomplish this safely, we use standardized order sets and protocols to systematically manage the many different moving parts. Traditional treatment algorithms have used IV infusions of regular insulin and transitioned to subcutaneous insulin after closure of the anion gap, with subcutaneous insulin being the long-term cornerstone of therapy for these patients. Decades of research have shown that, for the right patients, rapid-acting subcutaneous insulins are safe and effective in the treatment of DKA. There's a Cochrane review on subcutaneous insulin in mild to moderate DKA from 2016 showing no difference in treatment outcomes and adverse events compared to IV therapy, and a brand new systematic review and meta-analysis published in August 2024 looked at data from 245 patients from 6 RCTs and 8,444 patients from 4 observational studies, which again demonstrated effectiveness of subcutaneous insulin with no difference in mortality or hypoglycemia, among other findings. With all of this emerging data, I'd like to review 2 recent publications that report on outcomes after implementation of hospital-wide subcutaneous DKA protocols in adult patients. Evaluation of outcomes following hospital-wide implementation of a subcutaneous insulin protocol for diabetic ketoacidosis, published in JAMA Open in 2022 by Rao et al., and the SQUID protocol, subcutaneous insulin and diabetic ketoacidosis, impacts on ED operational metrics, published in Academic Emergency Medicine in 2023 by Griffey et al. I'll include links to the papers in the show notes. Before we dive into these publications, some of you might be thinking, why even bother with subcutaneous DKA protocols? We know IV insulin works to treat DKA. We've been doing it for years, so why change that? The reason is, there are many possible benefits of protocols that use subcutaneous as opposed to IV insulin. The main benefit is around resource use. Because of safety concerns and high nursing demands, most hospitals require that patients on IV insulin infusions be managed in ICU or step-down units. So these patients either go to ICU or step-down, or they stay in the ED until their anion gap closes and they can be transitioned off IV to subcutaneous therapy, and only then can they go to a general medical ward. Using subcutaneous insulin up front could allow these patients who would otherwise require admission to ICU or prolonged stays in ED to be admitted sooner to medical ward beds, freeing up precious ICU and emerge beds for the patients who need them most. Building off this, proponents argue that subcutaneous insulin protocols are easier and quicker to administer for nurses, freeing up valuable nursing time in the ED setting. I also think to really appreciate this topic, we should take the time to review a bit about the pharmacology. Most of the time, when we think about IV infusions in the ED, we think of medications that exert their effect rapidly and wear off rapidly, because for these drugs, infusions allow us to titrate them to a very precise therapeutic effect minute by minute. Norepinephrine, nitroglycerin, and esmolol all fall under this category of quick on, quick off titratable medications. Insulin doesn't have the same minute-to-minute titratability, nor does it need to be maintained at an exact level minute by minute for it to be effective, so it doesn't stand to benefit as much from infusion. Per up-to-date LexiDrug, IV regular insulin has an onset of effect of 10 to 20 minutes, reaches peak effect 5 hours into the infusion, and the effect wears off 1.5 hours after stopping the infusion. Subcutaneous insulin Lispro has an onset of effect of 20 to 30 minutes, reaches peak effect between 2 and 3 hours, and the effect wears off entirely by about 6 hours. So really, the onset of effect is quite similar, especially when you consider that setting up an infusion takes more time than just administering a subcutaneous dose. You can conceptualize a single bolus of rapid-acting subcutaneous insulin as being roughly equivalent to an insulin infusion of that many units that is predominantly released over 3 to 4 hours. Part of the reason our DKA protocols use IV insulin is that when IV treatment protocols were initially developed, the more rapid onset and rapid acting subcutaneous analogs like insulin lispro and aspart didn't exist yet, so they weren't even an option. So from a pharmacology standpoint, rapid acting subcutaneous insulin makes a lot of sense for DKA. But as with anything in medicine, there are always caveats. A couple caveats are that the rate of subcutaneous absorption can be negatively impacted by impaired peripheral perfusion and vasopressors, so shocky patients should definitely get IV therapy. Very high peripheral adiposity may also slow down subcutaneous absorption, so extremely obese patients are also more likely to benefit from IV therapy acutely. So now that we've reviewed the main reasons to consider subcutaneous protocols as well as the pharmacology, let's get back to the papers I mentioned. Up front, it's important to recognize that in both of these papers, subcutaneous insulin protocols were approved and rolled out hospital-wide as a standard therapy for all DKA patients meeting inclusion criteria, not an experimental therapy, because there was already enough pre-existing safety and efficacy data in the literature to support it. The primary goal of these studies was to see how implementing these protocols at scale would affect hospital operational metrics. I think it's important to recognize that because these studies aren't experimental studies, they're more accurately QI studies. Unlike RCTs, which are designed to be inherently generalizable, QI studies are highly specific to the institution and locale where they were implemented and may or may not be fully generalizable depending on local resources, culture, and patient population. But I think there's still a lot we can learn from what these hospitals found after implementing their protocols. The first paper by Rao et al. In JAMA Open in 2022 documents a subcutaneous DKA protocol implemented in a large hospital in San Jose starting in 2016 that uses an upfront bolus of long-acting insulin of 0.3 units per kilogram, or the patient's home dose, as well as short-acting insulin lispro with an initial bolus dosed at 0.3 units per kilogram and repeat lispro dosed every 4 hours based on blood sugar. In addition to parameters for fluid and electrolyte replacement, which closely resemble traditional protocols, their protocol uses glucose monitoring Q2 hours for at least 4 hours after the last dose of short-acting insulin, with electrolyte monitoring Q4 hours. Inclusion criteria were adult non-pregnant patients with GCS greater than 8 and no concurrent conditions that would otherwise require ICU admission, such as shock. Interestingly, they did not use any strict lab cutoffs of DKA severity as exclusion criteria, meaning that some patients that had severe DKA by lab criteria alone still got subcutaneous treatment. They report data from DKA patients over 9 years, comparing outcomes pre- and post-hospital-wide implementation of the subcutaneous protocol, and they also compared outcomes to a very impressive control group of 20 comparator hospitals which used traditional DKA protocols during the same time period. They found that in the intervention hospital, the use of initial subcutaneous insulin therapy in DKA increased from 13.4% of DKA patients to 80.3% of DKA patients after the intervention, suggesting very good uptake of the protocol. The overall dose of insulin received in the first 48 hours was the same regardless of subcutaneous or IV protocol. Post-intervention, they found that there was an impressively decreased ICU admission rate by 57% for DKA patients at the intervention site compared to standard care sites. Notably, there were no increase in hypoglycemic, adverse events, or mortality at the intervention site compared to the pre-intervention period or non-intervention hospitals. This protocol was rolled out in Kaiser Permanente San Jose Medical Center. I did correspond with the authors of this paper, and it turns out that this protocol was so successful, they have expanded it to all 20 other Kaiser Permanente hospitals in Northern California that were involved as the comparator group in this study. So we can expect a lot more data from this group to be published in the coming years. The second study, by Griffey et al. In Academic Emergency Medicine in 2023, reports on the implementation of a subcutaneous DKA protocol in 2021 at an academic hospital in St. Louis. They included DKA patients with a pH of greater than 7 and bicarb greater than 10, and like the previous study, they excluded sicker patients who would likely need ICU admission for reasons other than just IV insulin, such as shock. Unlike the last protocol, they don't start with an upfront long-acting dose. Their protocol uses Q2-hour sugar checks and Q2-hour Lispro boluses dosed based on the sugar, and Q4-hour electrolyte checks. They compared outcomes of patients getting subcutaneous or traditional therapy over a total time period of 7 months, with a total of 78 DKA patients getting subcutaneous protocol and 99 getting traditional protocol. They achieved a 3-hour reduction in ED length of stay for mild to moderate DKA patients on the subcutaneous protocol compared to those on the traditional protocol. There was a signal towards decreased ICU admission, but it did not reach statistical significance. As with the previous study, there was no difference in hypoglycemic or adverse events between the subcutaneous and traditional protocols. Interestingly, though the protocol itself called for Q2-hour glucose checks, on average, the patients on the SQUID protocol underwent glucose checks Q1 hour, possibly suggesting an abundance of caution by the care teams implementing a new protocol. So what are the takeaways from these two recent publications? Well, it tells us that these US hospitals have safely and effectively implemented two different hospital-wide subcutaneous insulin protocols for managing DKA, not as an experimental therapy, but as a standard care for all eligible patients. In doing so, they have managed to either reduce ICU admissions or ED length of stay, respectively. In the end, for mild to moderate DKA patients, the type of insulin doesn't matter nearly as much as the treatment protocols being effectively implemented. DKA treatment is a team sport with a lot of moving parts, so any DKA protocol requires good education and buy-in from the nursing and physician teams in the ED and inpatient wards. I did correspond with authors from both papers, and a key takeaway is that these protocols were designed with multiple stakeholder engagement, and implementation involved very robust education for the physician and nursing teams. When expanding their protocol to additional sites, the Kaiser Permanente group found it was ideal to have multi-pronged leadership, including an ED physician, hospital physician, and nurse leader working as a triad during the implementation phase at a new hospital. Ultimately, in a day and age where ED beds and ICU beds are stretched thin, it does make sense to implement therapies that are more cost-effective, less resource-intensive for nursing, and can free up higher acuity beds. And I think we will slowly see more and more hospitals make the switch, just like the hospitals in these studies already have done. But from a practical standpoint, we know it's important that DKA management follows a standardized protocol, so you should still just use whatever protocol and order set is standard in your hospital. And if subcutaneous protocols sound interesting to you, maybe do some research and get in touch with your local hospital stakeholders, and you can be a champion for introducing one of these protocols at your hospital.
Thanks so much, Dr. McArthur. Last but not least, I've dug into the archives and found a gem of a quick hit that I recorded at the Canadian Association of Emergency Medicine Conference in 2022. It didn't make it into the Quick Hits 45, where Dr. Jennifer C. Tang talked about 4 medical legal myths, but it's a great nugget of medical legal advice. So here it is after we hear from one of our sponsors, Metricade. Since 2015, I've been using Metricade, the incredible self-scheduling system that has made my life and the lives of my colleagues so much easier. Metricade can really help minimize the drawbacks of shift work we all know so well by not only ensuring equitable distribution of shifts, but also integrating circadian rhythm-friendly recovery time into their algorithms. They minimize my sleep deprivation, which allows me to be a better EM doc on shift. I can take better care of my patients and still have energy left after my shifts to enjoy other aspects of my life. Check out metricade.com/emcases for more details on how this awesome scheduling system works. So the third myth I wanted to talk about was the one that if you document a wide differential diagnosis in your chart, you should investigate each of those items to rule them all out. Can you tell us a little bit more about what sort of best practice is in terms of how to document the differential diagnosis, what you're thinking about, and what's required in terms of the workup of that differential diagnosis?
Sure, and I can say a few things. I will say that the CMPA website has a fantastic e-learning module on documentation There are CME credits associated with that learning module, so I encourage everybody to check out the e-learning modules at the CMPA website, and there's an excellent one on documentation. So just like you said, you're not expected to investigate every differential diagnosis you put down. It is important that you document why you think it's unlikely if you're not investigating. There's a few reasons why documenting is helpful and good for safe medical care. It helps demonstrate your rationale for your investigations and management. It helps with your cognitive processing, your diagnostic reasoning. It helps you saving yourself from potential cognitive biases, like anchoring. It speaks to your thought process, kind of like when you were in grade 7 math, showing your work before you get to the final answer, showing anyone who reads the chart that you considered this serious diagnosis but ruled it out because of X, Y, Z. It helps give context to your discharge planning. We talked a lot about discharge instructions. You can say, if you have signs and symptoms of X, please return to the Emerge ASAP. So I think there's a lot of our colleagues who are worried to write down a differential diagnosis. The classic one is the medical student who may write AAA on every single abdominal pain. And it's important not so much to be afraid of the differential diagnosis being written down, but provide a rationale as to why you think this is more likely or less likely.
Yeah, my personal experience has been over the last year that I've started dictating on almost all my patients. And I find that dictating really does force you to think about the details of your assessment, your differential, the discharge instructions, every step of your entire experience with each patient. It really makes a huge difference actually dictating compared to just jotting down some notes on the chart. And that's just been my personal experience. I feel like I've become a better doctor because I've been dictating my charts, and it's actually given me sort of a little extra challenge. I found it very difficult at first to start dictating because it slowed me down a lot. But I think overall, once you get used to it and you've built the skill, it feels good to have a new skill like that. And I think it's made me a better doctor. I think it's better for my patients. That's just been my experience. In terms of dictating versus handwritten notes, do you have any thoughts from a medical legal perspective?
I guess it depends on how neatly you write. My own institution's going through a change, and by the time I come back from this conference, we'll have an electronic medical record.
Wow, so your docs don't even have a choice to write anymore.
No. What I will say, from my perspective as a coroner who has to sometimes review charts, is that it is way easier to review an electronic chart, hands down. We are so concerned with providing excellent patient care in the Emerge. Sometimes you think faster than you write. And so the legibility, it's challenging. You can lose extra pages. I find it very easy to read electronic medical records and review dictations. The other thing I was going to say is that sometimes in the right patient, it's very helpful to actually explain to the patient your differential diagnosis thinking. A lot of patients, as you know, Anton, come with a lot of anxieties or fears, and they say, what about this? Why are you not ordering X scan? And sometimes verbalizing your differential diagnosis and your way of thinking to the patient shows that you've done your due diligence. You've thought about why they may not or they may have appendicitis versus ovarian torsion. And it helps them understand and connect that to the rationale for the return to the Emerge advice. I found that in the right patient and family member explaining that, it increases confidence and it's helpful to them to show that you've really thought about it.
Well, that about wraps it up for this month's EM Quick Hits. Thanks so much to Ross Prager for his insights into using TEE in cardiac arrest, to Justin Morgenstern for his take on the latest evidence for nebulized ketamine for analgesia in the ED, to Hans Rosenberg and Krishin Yadav for pushing us towards a standardized approach to cellulitis management, to Mathew McArthur for elucidating the benefits of subcutaneous insulin for DKA, and Jennifer C. Tang for her tips on documenting the differential diagnosis. For those of you who weren't lucky enough to attend November's International Online EM Cases Summit with more than 600 registrants who could make it, we've got you covered. You can purchase video streaming packages not only for the 2024 summit, but also the 2023 and 2021 summits at 50% off. This includes CME points, so if you need some last-minute CME points, this is a great way to get them. Many thanks to the amazing speakers and super engaged audience for their participation, making it the best online EM conference in the world. Thank you so much. All right, until next time, take it easy.